I want to thank Seattle Science Foundation and Swedish for providing a platform for this webinar and for helping us putting this together. Today, we have the pleasure of having with us Dr. Eytan Ras. He currently works at NYU Langone Medical Center in New York City, where he's an assistant professor working for the neuroradiology and interventional radiology sections. He graduated from Sapienza University of Rome School of Medicine in 2006, where he also obtained his radiology specialty in 2011. He completed his fellowship in diagnostic neuroradiology and interventional neuroradiology at NYU Langone Medical Center. He's the author of more than 80 publications in high impact factor peer-reviewed journals, such as Radiology, AGNR, AGR, JNAS, etc. His fields of expertise include neurovascular diseases, traumatic brain injury, and multiple sclerosis. In 2012, he was appointed editor for the Fellows Portal of AGNR. And well, there are many things to say about Dr. Ras. I personally follow his publications, his work, his lectures. He's an amazing teacher. His anatomical demonstrations and knowledge of anatomy and anatomy pathology are amazing. So welcome, Dr. Ras, and thank you for being with us. You can share your screen now.
Thank you so much for this introduction. Indeed, it's exactly because of what you said, of our interest, my personal interest and the interest of our group in imaging, I decided to put together this talk that I titled this way, From Anatomy to Pathology, the Power of Imaging. Quick thank you and Dr. McDougall and the Seattle Science Foundation for this opportunity. So disclosures here, I will show cases from using multiple products, but certainly, like, you know, one of the things that I will show a lot will be angiographic images done with we use Siemens, and so this is probably the most important disclosure. So I have to say that whatever I show is really like the product of our group work, and here is a picture with me with Dr. Nosek and Dr. Shapiro. We work together, we do things together. Everything I see is really the product of our work that we publicize in many ways, and you're welcome to look at our work in other ways. So the outline of the talk will be really like the lessons that we can get from high resolution vascular imaging. And this theme, I will follow this theme by going through essentially all neurovascular conditions that we deal with, but also like talking a little about possible opportunities in sort of like exploring new frontiers. Briefly, very quick, when we think about how did the imaging develop in the angio suite, like, you know, obviously the first thing it was the angiography, and we're talking about like the 1927 is when the first angiographic images were produced. And the next real big evolution was really the production of digital subtraction angiography that became really routine use in the 1970, which allowed a better assessment of the vessels. Now, the next big step was probably the rotational angiography. So people realized that by acquiring the images and rotating the machine during acquisition would lead to a better understanding of the vessel, but still there was no really like the availability of creating the 3D imaging. That developed a little later, like in the late 90s. People started to like realizing that those acquisitions could be reconstructed and develop real 3D images from that. And then what happened since then, we started to have better detector, like the flat panel detector that made possible like faster acquisitions, more precise acquisition, higher resolution. And so then other things started, the 4D imaging, the fusion, 3D imaging, arteriovenous imaging, needle guidance, all sort of like development that were allowed by better imaging. So we really like essentially in a century went from these to like capability of getting something like these. Let me clarify a few terms that I will use quite frequently during this talk. I work with Siemens, and Siemens is our machine, but the same imaging can be done with the Philips, with GE, with other vendors as well. Now in Philips, when we talk about cone beam CT, the term is DynaCT. What is it? It's a rotational acquisition of a single volume, which can be done with or without contrast classification, usually over 20 seconds. Yes, there are shorter acquisitions as well, but the one over 20 seconds that provides the biggest resolution. What are the common uses of this? The common uses is whenever we need a CT head in the angio suite. Okay, that's what we do. Whenever we do a post-flow diversion or post-web imaging where we want to see the device and the vessel, and we see the relationship between the two, that's what we use. And then there's a 3D DSA. What is it? It's a rotational acquisition of a volume, usually twice, with a mask followed by contrasted one, and usually it's shorter, it's over 6 seconds. This is really like the common use, is the most obvious use is during aneurysm angiography, to understand the aneurysm, to understand better like what the projections, sometimes for AVM. Now, these protocols can be used in many other ways, and that's what I will show essentially in this talk. And also, one of the questions is how to maximize the resolution with using this technique. And one of the way is the following. So this is just the resolution you have with a normal 3D DSA, okay, showing the vessel very well. It shows the aneurysm, a ruptured aneurysm, by the way, shows probably an infundibulum of the picon, but you're not sure. Now, if you want a better resolution of this, you can get a DynaCT, a cone beam CT. And with the cone beam CT, when you look at the same vessel, now you understand a little more. So you see that indeed, for sure, this is an infundibulum. You understand a little better the shape of this aneurysm. You see, essentially, you see more. Now, is there a way to maximize this even more? Yes, there is. And it's about post-processing, okay? It's about post-processing of the images that you acquired. And if you post-process by acquiring a smaller field of view, that's what you get. Now, this is the same aneurysm, it's just post-processing on the same image. Now we see the infundibulum of the picon. We see actually a little perforator coming from the proximal picon. Now we see the aneurysm, and now we see a few things. We see the choroidal artery coming from it, but we see also there are other 2 perforators coming from it, okay? And now we understand this much, much better. So this brings me to start the talk by talking about aneurysm. So going back to the same case, if you see something like this and you want to understand more, you rotate the image, and that's what you get. Now, wait a second. Now you look at this image, okay, there's the choroidal coming, as we said, that this is obvious, but there's another perforator, and this perforator comes exactly from the aneurysm sac, right? Something that we're taught it almost essentially doesn't happen. No, it actually does happen. It's just very often, it's hard to realize when it happens. There's another perforator coming from the back, and then you see the aneurysm better. You see there are a lot, obviously, blister on the aneurysm. This is a ruptured aneurysm. We need to treat this. And what do we do with something like this? We coil. But interestingly, we didn't realize about this during the case. So we coiled it and we closed off, not an exceptional coiling, but enough to close off the part that really looked mostly regular. And we were happy at the end of it because the choroidal was open, and we didn't realize indeed that perforator that was obvious with the post-processing we did later on, now it's closed and you don't see it, right? Now, because of this, we got an MRI that proved exactly there it is. You had a little infarct in that perforator that you closed during coiling. In this particular case, this didn't have much clinical impact. This was asymptomatic, but this is a very good case to show the example of how you can understand sort of very small branches that otherwise on your 2D imaging would be, or your traditional 3D DSA would be impossible to recognize. So in the role of DynaCT, or use of cone beam CT in aneurysms, is really has a role to show things with a higher resolution. So as I show you in the other example, this is another one. You have a big pericallosal aneurysm, not really need to understand this much more in detail. But if you want to, this is what you can get. You can get incredible detailed images of it. Okay, combination, again, right protocol and right post-processing. You can understand the features of the aneurysm, perforators from it or around it. But also there are situations where you need to identify aneurysms that are very small and otherwise you cannot. Another example of using high resolution imaging to make decision, this is a patient with unruptured aneurysms, an MCA and an A1 aneurysm. If I show you this image and I ask you, do you think we need to treat this? We probably would be in the idea, like if we make a poll, most of the people would say we would not treat, but you know, maybe somebody would say yes. But if I show you this, the separate reconstructions of both aneurysm, look at this MCA aneurysm, look at how irregular with a little bubble coming from it. And look at this A1 aneurysm. This A1 aneurysm, like bilobed with a little daughter sac here. Like now, if I ask the same question, would we treat or not? I'm sure somebody may change their mind. Okay, so understanding the feature, looking at it in more details may indeed show things in a different way. Now, another example, question of mycotic aneurysm in a patient with endocarditis, a tiny amount of subarachnoid hemorrhage, in our lab, this patient goes to angiography and we do the angiography, and you know, I challenge anybody to tell me that there is an aneurysm on these images, okay? And you get a Dyna CT, and now in the Dyna CT, you look at it in detail, and it becomes obvious that there is an aneurysm, right? It's a little kind of fusiform mycotic aneurysm, and you understand it, you can look at it in different perspective, and now you can even go back to your 2D, and when you go back to your 2D, now you see the same projection, you can get the same projection, and now you look at it and there it is. It becomes obvious that there is an aneurysm there, right? The role of imaging. Another patient, like with a subarachnoid hemorrhage, like sort of like a diffuse, but also like in the posterior fossa, obvious dissecting aneurysm of the intradural vertebral artery, like sort of like codominant, a little dominant on the right, but certainly this is a patient that can sustain the flow just only using the left vertebral artery. You see a pica coming from here, right? So like this is a very reasonable situation where to sacrifice this, like close off, sacrifice this vessel, cure the aneurysm, and that's it, right? Can you just do it? Yes, certainly you can just do it. But if you want to take a step forward, understand things in detail, before moving to a sacrifice of a vessel, like you can get certainly like better imaging. If you get better imaging, in this case, a Dyna CT, this is a MIP reconstruction of the Dyna CT. You can also do a 3D reconstruction of that. Now you see things a little more in detail. So what do you see? You certainly see the pica. We knew about the pica also from the 2D images, no question, right? But you see a little more. You see there is anterior spinal artery coming from here that is kind of hard to see, understand on the 2D. You see it better here on the MIP. Okay, and you see also another branch coming from just past the aneurysm. This is like essentially like an accessory, you can think of it as an accessory pica just supplying the cortical surface. So yes, there is a big pica, but there is another little branch that will supply the pica territory. So now when you think of sacrifice, like without understanding this, you may sacrifice even from here all the way because these are vessels you don't see. But once you understand this, it becomes obvious that you have to sacrifice much more limited and preserving these vessels. And that's what we did. We sacrifice here, the pica is patent, and when we inject from the other side, you see that there is the anterior spinal artery filling and this little cortical pica branch filling. Another example, patient with subarachnoid hemorrhage, like very mesencephalic here, and this was like again 2D image is almost like, I mean, retrospectively, maybe I see something here, but it's really hard to understand there's anything. This is one of our first cases where we really like started to use imaging in like a little more specific way. And, you know, you do a 3D, these are, you do a 3D, like you don't see anything here, right? What you do, you turn the image and there it is. You'll see a little, very, very small basilar perforator aneurysm that was the cause of the bleed. We decide to wait, and 1 week later, you see now a little bigger. Here you see like the aneurysm grew, and these are again images of that shows really the perforator coming from there. Basilar perforator aneurysm. In other patients, subarachnoid hemorrhage, like again, sort of like posterior fossa hemorrhage. Again, I challenge anybody to tell me that what's wrong on these images. You look at these, there's really nothing here, right? Maybe there is a little spasm, but really it's hard to say there is any aneurysm. And this is a patient where you do a Dyna CT. And when you do the Dyna CT, look at that. You see a little aneurysm coming off from, essentially from, you can call it an accessory superior cerebellar artery, duplicated superior cerebellar artery, but that's certainly like the aneurysm, the culprit of the hemorrhage. So other roles, you know, I showed you like example of clinically relevant roles. Other roles, more understanding. Generally, we always talk about the superior epiphyseal aneurysm, right? Why we call them superior epiphyseal? Because we know where they are. That's a position where we know the superior epiphyseal artery come from. This is an example where you actually do see the superior epiphyseal artery coming from it, right? So just generally speaking, like it gives more understanding, okay? And gives more understanding is really, having more understanding is really like a good base to try to go to the next step. So this is an example. You see like here a small, this was a patient with an ACOM aneurysm as well. Like you see this little superior epiphyseal aneurysm, and you see this hypophyseal artery coming here and supplying the pituitary gland. So moving forward to the next topic, where high resolution imaging really has a role, is fistulas. And I said fistulas because I will talk about dural AV fistulas as well as carotid cavernous fistulas. When we think about dural AV fistula, it's really like, you know, this is a little basic, but you know, it's a cranial or spinal vascular malformation, which consists of a pathologic shunt located within the dura mater. Now, in a dural AV fistula, we believe there's no nidus proper, differently than a brain AVM. But sometimes there are some vessels that really look like a nidus. So why? Because essentially they are convergence of vessels, convergence of arteries that converge all the way, then to connect, that then connect with the vein. And this is an example. This is a DynaCT that shows this very well. Here, let me pause this. Let me come back. Here you see all the arteries converging here. You see like this is obviously a sagittal view, mastoid bone. You see the sigmoid sinus. They all converge and then they go along the arterial arcade. But then this is the hole. This is the fistula. You see the artery here, the arterial arcade. This is the vein, and this particular here is the hole between the artery and the vein. So this is the fistula. All the rest are only all like other arterial supply to the fistula. Now, the reality, what is it? That usually in dural AV fistula, you don't have only one hole, you have multiple holes. And here, for example, I show you the other hole in this patient. There it is. Here you have another hole. If you follow the arteries, here you're going to see that they're connected there with another hole. And then on the back, there's going to be another hole here. So you can really number the holes that you see in a dural AV fistula if you end up having better imaging. So the presence of this arterial arcade is something that we know from Lajoniak, Claude Vachon in this incredible drawing that is still like so real in every case we do. And you see like these arterial arcades along the sinus, and it's so these essentially these are the ones that becomes hypertrophied with AV fistula, but then they find the hole with the sinus in some ways like this. And you know, when you have something like this, you do a 2D, you have a dural fistula, you have a 2D DSA, you inject, you see like sort of like a mess here. It's really hard to understand. And it's only by doing your DynaCT that now you understand. You understand this is the same case. You understand that everything converges here, and this is the connection between the artery and the sigmoid sinus. So this is the vein, this is the artery, and this is the fistula. How to apply this in practical ways, like with treatment. This is an example. This is a patient who was treated somewhere else, and initially like seemed to be occluded, but then recurred and came to us to complete to do a second stage treatment. And you get this sort of like 2D DSA, common carotid angiography. There's obviously a fistula, like this. You see this early opacifying sigmoid sinus internal jugular vein. A lot of arteries here going here. You can act on these in many ways. This sinus was needed, so it's better to preserve. Now, if you get a DynaCT in something like this, you understand it better. Now you see the onyx from the prior treatment, and now you see the same thing. You see a sigmoid sinus, right? And here it is. You see like this sort of like connection between the arcade and the vein. And when you see something like this and you decide how to treat, it becomes a little more like you can be a little more sophisticated than just like sacrifice the sinus, because you can think of just going inside here and you go from the vein, and you find it. You found the way in, and when you find your way in, you're essentially in the arterial side, and then you can do many different things. You can inject onyx, you can coil it off, but once you close these, you essentially treat the fistula. And this is before, and this is after, just a selective, we call it a selective transvenous embolization of dural AV fistula, something that Dr. Shapiro will talk about much more in a couple of weeks from now. This is an example of a cavernous fistula that was actually missed a couple of times on MRI. And the reason why it was missed on MRI is because the MRA was not done. And, you know, when you look at just an MRI and you look at T2 and post-contrast T1, sometimes understanding and realize that there are increased vessels, it may be something you need a little eye for it. And, you know, just scrolling through, you may not appreciate it at first glance. So, but once you see this, then you start noticing other things. You notice the arterialized flow in the cavernous sinus. And then on the post-contrast, you start seeing a little like venous congestion on this side of the brain. This is a high-grade cavernous fistula, comes for angiography, and the fistula is obvious here. Like the interesting thing is like when you get the images from the other side, in this case from the left contralateral semipharyngeal artery, you understand the venous outflow so much better because you don't have the superimposed MCA here. And you see how the fistula drains like to the deep sylvian vein, essentially to all the right MCA, the right hemisphere, and then from there it goes to the cortical veins, to the superior sagittal sinus and the transverse sinus. So these correspond really like to the increased vein that you saw on the MRI. Now, when it comes for angiography, we do a DynaCT. And this is the sort of imaging that you can get, certainly like beautiful images, but, you know, I want to express the fact that this is more just than beautiful imaging. It can really like give you hints on things, okay? And this is an example of something that is very beautiful, very detailed, and you can work on these images and understand things better. These are 3D reconstruction of the DynaCT obtained with contrast, obviously. When you look at these images separately and you start looking at the sort of like this cross-sectional that comes out of it, you start understanding the compartments of the fistula. You can start to understand which compartment really you need to close this fistula. You can also understand better the approach that you can have for it. For example, in this case, even though the flow went all to the right hemisphere, it seemed that there was a very small, but there was a little inferior petrosal sinus. So we try to go from that route, like to essentially a thrombose or a thrombose hypoplastic inferior petrosal sinus. We went very, very gently through it, and then we found our way to the fistula from the back. And then once we got to the fistula, then it's really just a matter of like, you know, you can coil it off. Just be careful not to close your way out. But once you get to the fistula at this point, the case becomes much more simple. Again, in a case where, let me go back, there's no obvious inferior petrosal sinus outflow. So there's like essentially you have to find your way through unoccluded inferior petrosal sinus. Another example of a cavernous fistula in which the DynaCT became very useful is this one. Is a patient again where you see this little like increased vascularity here in the like increased veins, congested vein in the frontal lobe, this phloboid in the posterior cavernous sinus, and with the MRA here is going to be very good to make a diagnosis because it's going to show the high flow. So diagnosis is made, comes for an angiogram, and this seems pretty challenging because, like, again, like you see the fistula obviously, but you don't see any outflow of the fistula to the inferior petrosal sinus, and you see a lot of congestion in the brain from it. And when you look at it on lateral, there is some outflow to the ophthalmic vein. So that certainly can be a route, and I'll show you a case next of like approach through that way. But you know, this is a challenging case because how do you get there? Again, like, can we try to an inferior petrosal sinus? Maybe. This is a contralateral injection, again showing better the venous outflow of it. Injection from the left ICA, from the left external, and then we get the DynaCT. And this is where the magic happens, because you get the DynaCT, now you look at the images in detail, right? And then the idea comes to mind, okay? Where to go to this fistula? You see the fistula here, the outflow, it comes like this, and then goes to the lateral cavernous sinus, to the deep sylvian vein territory, right? But if you look at this image in detail, right, there's something a little odd. it seems there is a little cutoff of this here and here. This is the superior petrosal sinus. This is the, it seems like there is a cutoff. So maybe this was a vessel. It was a vessel like this and that partially thrombosed, right? You look at it on axial, or you look at it on sagittal. Look at this, even on 3D, it looks the same. Like it seems there was a continuation that somehow got thrombosed. So that's where the idea comes from. Let's go through this. Let's go through the superior petrosal sinus. Let's try this route. Is there a superior petrosal sinus? Yes, you know, from the vertebral injection, you see that there is a superior petrosal sinus, just like the distal part of it, but we know we're gonna be able to get there. So we get there. We go inside with a little microcatheter, and then when we get here, very gently advancing, very gently trying to advance, and there it is. Very gently, we get to the fistula, and now we're in the fistula. Now, once we're in the fistula, again, this is just a matter of like what to do. Okay, we do a little angiography to prove, like you see the venous outflow from the fistula a little better. And then we coil. Again, careful not to occlude your way out. Make sure you coil all the compartment, everything that comes to it. But, you know, at that point is really like, becomes an easy case once you get there. And these are the images post showing a cure of the fistula, improvement of the venous congestion. Again, understanding how to get there using your DynaCT. Next case, this is again a cavernous fistula. This is a case that very similar in terms of imaging here on this external injection. You see a little something a little different than the other case, which is a supply from the artery of the foramen rotundum, from the clival artery, which in this case was supplied by the occipital artery. Again, you understand better the venous outflow by the contralateral injection. Okay, here this is the supply through the meningoepiphyseal trunk with the clival branch. So let's not mistake this for a vein. This is an artery that comes from the other side, right? And you can get 3D images. And if you get 3D images of the other side, you have a very good representation of the vein on the right side. So by looking at the vein, then you can decide your approach. Now here, we decided to try a transarterial approach first. So we went through that clival artery. Okay, we got in a very good wedge position where when we were injecting, we really had control of the flow and very good feeling of the fistula. Can this be a glue shot? Can we inject glue from here and close the fistula? At first glance, you may say yes. But if you look at these images in detail, there's something in the image that tells you that you cannot. What is the problem here? And again, having DynaCT images, like to compare your 2D, is going to be very useful, like to understand things better. And here, if you see this in detail, there's this particular thing. You see this little hole here, and here on the clival branch, you see this little shadow. What is it? This is the carotid artery. So if you do inject a glue from this position, it seems at first glance seems very promising. You're gonna have some embolization in the ICA territory. Okay, so this is really like one way, like to look and understand your safety. So in this case, transarterial, no good. Okay, so what can we do next? This is a case that you know, we thought we could have done like a direct transorbital approach. So this is where really like your imaging planning becomes very useful. You have that view from the other side that shows the vein very well, and you can do your views. This was described many years ago, and something that can become very helpful to know. And then you select your view, like you have your guidance and go with the needle. Once you're with the needle in the fistula, then you know it's just a matter again, like a matter of like closing the fistula with coils. This is just to show like how to get there. You want to be inferior to the orbit, lateral to the optic foramen, essentially in the inferior medial part of the superior orbital fissure. And this is just the result of this case that we actually put a video together to on JNIS about. Another case, 25-year-old post-trauma, carotid cavernous fistula. Obviously, inject the right side. You essentially don't see the filling of the right ICA. What you see, you just see filling of all the other veins. You know, any case like this, it becomes like a lesson of venous anatomy. Okay, and you see here the filling of the contralateral inferior petrosal sinus, the cavernous sinus, and so forth. And when you inject from the left, now you're going to see filling of all the brain, right? And feeling even retrograde to the fistula. Now, can we sacrifice this vessel? Probably yes. This is almost like a pass. It's essentially a balloon test occlusion pass, right? But in this case we actually didn't. But this, I'm showing you this case just to show you like how can you put together different images and really like understand things just better. Right, this is like a fusion of the left and the right 3D that becomes sort of like an arteriovenous 3D, and this is just a little debrief. It's something that we explored mostly like really like for clinical, for teaching, for anatomy understanding. You can get essentially two separate 3Ds. One of the veins, one of the artery. One of the arteries is very easy to get. One of the veins, you really have to time it well. And but once you have them, you can fuse them and create these beautiful fused images that, you know, sometimes can have clinical roles. For example, in this case, like this aneurysm was going to coil, is really like prove useful to a surgeon to know exactly where the veins were compared to the aneurysm. Something that we put together that we find sometimes useful, and you know, you can create very good representations of these. That, you know, no questions how beautiful they are, how useful they are. It depends really like on role. I'm sure you guys can find some role for this. In this case, it is a fusion, and what this fusion, these images show, when you start looking at the cross sectional, you understand things much better, because you see like this is the right side, this is an axial view, this is the right side, this is the carotid, and now you see the whole, right? Look at this. This is the hole. This is the tear of the vessel. So you understand very well which compartment you may need to close, right? But from this image, what happened, what became like so like fascinating to me is the visualization of the contralateral cavernous sinus. Now you feel the contralateral cavernous sinus without feeling the carotid when you inject from the right. And now you can see things so much better, like in terms of normal anatomy. And these are 3 reconstructions of that. Right, we know our anatomy of the cavernous sinus, and look at this. We see this is the carotid, okay, the brain there. We see the carotid there, right? Again, sagittal, coronal, axial, and then we start seeing what else? This is the trigeminal ganglion, right? And what is this? This is the 6th nerve crossing through it, right? And what is this? This is the oculomotor nerve, right, more anterior. So this is just a way, like, you know, how imaging, you can certainly have useful use for clinical roles, but also like really like academically to understand things in a better way. AVM, so for AVM, like, you know, certainly like the 4D DSA can give you a better understanding when it's a big AVM. For small AVM, especially in the posterior fossa, we think the DynaCT is actually a better way to go. And this is an example of a patient with a ruptured small AVM of the cerebellum, and you see here the early venous drainage in the precentral vein and this cerebellar vein, and we get a DynaCT. But if you get the DynaCT and you just look at this is not going to be like, it's not going to help you so much. You have to do a small volume VOI. When you do a small VOI, like, you see things in a magnificent way. And I put just here a marker to like let you understand how magnified this is. You know, this is a precentral vein. You see, this is 5 millimeters. This is quite magnified. And now you try to understand things better, but you have to keep in mind the flow. So on the DynaCT, you're not going to understand the flow. You're not going to understand the dynamic of the flow, okay? It's one picture in time, okay? So keep in mind how is the flow, and this is the run, right? That shows like, again, the early venous outflow there, and now you start to seeing another vein there. But what's the relationship between the two? That's what the DynaCT will tell you, okay? This is an early arterial phase. This is sort of like a normal venous phase. Now, when you look at this DynaCT, you see a little AVM right here, which drains through this little vein. Okay, this is the vein draining the AVM. And then from there, the AVM drains like inferiorly through this vein, through this sort of like posterior cerebellar vein, and through this precentral vein, okay, through both directions. But now, and these are the veins on your 2D. But now, here on the DynaCT, we understand that there is another vein that we don't really like see the outflow from the AVM. Okay, so this other vein here, and then there's another vein there, but now we understand that these veins actually are not used by the AVM. These are veins of the normal cerebellum that drains in the same location. So if we do just decide, okay, let's go there and close this whole vein, right? Let's just do a transvenous embolization from here, and let's close this whole vein. Like, we put in danger part of the cerebellum and the brainstem here, because they don't have any more their outflow. So this is a patient that in our lab went to surgery to do a selective resection of the AVM, closing this vein by preserving these veins. Another example, a patient with a hemorrhage of the posterior midbrain, and you see here there's obviously like what looks like an aneurysm there. Now it's hard to understand, is there may be some early venous drainage here, but really hard to understand unless you do a DynaCT, beautiful images. Like, look at this midbrain here just to understand you're in scale, like you see the aneurysm, but you can play around with it. You play with it, and this is a 3D, the 3D of the DynaCT. You play with it, and you try to understand what supplies the AVM. And now you see this vessel comes from here. It's a collicular artery that comes from here, and then comes back here, and rotate around and goes to the AVM. Now, once you identify this on your imaging, then like you know exactly where to go. You go like to this vessel here, and you know where to go. You know what catheter to select, and then you get there, and then you close this AVM with a little flow-related aneurysm. This is the post-glue embolization, selective injection, just closing the aneurysm, and certainly no aneurysm visible anymore. Like, will there be any residual AVM or not? We will ascertain that in a follow-up. And this leads me to the next topic, which is application of this imaging for, generally speaking, vasculopathies. Okay, and this is really like where like understanding things more in detail can have an impact. And you know, moya moya, when we think about moya moya and the collateral that we see with moya moya, you know, we call them moya moya collaterals. But if you want to understand them better, and you know, in an academic setting, you may want to, right? You may want to understand this better, like, you know, it's not going to make a big difference probably like in most of the cases, but if you want to do that, there's no substitution than getting more higher resolution imaging. This is like a reconstruction from a 3D, a MIP. You can really like follow the vessel, and this is an example of how you can understand the collaterals better. We know that there is like a potential connection in every individuals between the ethmoidal arteries and the anterior cerebral artery through the essentially the olfactory nerve. And this is an example of an anterior ethmoidal artery in a normal patient that you can really follow very well with this sort of imaging. We know that in patients with moya moya, this potential connection becomes a possible source of collateral to the brain, what is called like the ethmoidal rete. And this has been described very well, but how well can we see that? And this is an example of a patient with moya moya, and this is where you can follow it, and you see the ophthalmic artery coming up, and then here you see there it is. You see the connection, and then you can follow the connection with the all the way to here with the territory of the anterior cerebral arteries. And this is like a big MIP putting things together. This is the ophthalmic artery, this is the anterior ethmoidal artery, this is the anterior meningeal artery, anterior ethmoidal artery here connecting with essentially the anterior cerebral artery territory. And this is just like the same thing, looking at it. This is a posterior ethmoidal artery. This is the anterior ethmoidal artery connecting with the rest of the brain. Again, like an axial view to understand this a little better. But again, like it's with the application of the right imaging, you can understand these things in more detail. This is a patient with a hemorrhagic moya moya. Like you see this hemorrhage here. You maybe a question on the CTA, is there something there or not? You get the 2D is like a mess. Like you see, like it's very hard to understand anything with her 2D, and it's really just by like doing, in this case, actually a normal 3D DSA that you understand there is an aneurysm there that becomes really like the target for the intervention. And you can play around with it, understanding the route where to go, something that can be very hard otherwise. And once you identify target and you identify how to get there, you know, the coiling becomes something relatively straightforward. Dissection is a topic that you know, it's relatively rare condition, but we believe it's more common than what is believed. And we believe that it is more common than what is thought. The problem is that it's hard to diagnose. Sometimes, why? Because the intraluminal clot is indistinguishable from essentially from a dissection. So when you deal with strokes, and it's maybe very hard to distinguish that in the acute setting. But when the vessel opens and then reclose, think about it, okay? Because these are situations where you may deal with a dissection, and you know, to distinguish this, the cone beam CT is very important, and I'll show you a few examples. Okay, so this is a patient with you know, what certainly with some hypoperfusion of the left MCA territory. Okay, comes for angiography, and you see there's certainly some stenosis here that you know, you may not really understand very well unless you do the proper imaging. And once you get the proper imaging, which is in this case is a cone beam CT, you magnify this particular region and you look at this, and now you understand this better. This is the M1, this is the M2, and this is the other M2. There's certainly a stenosis here. But when you play around this, you understand that there is like a double lumen, sort of like a pseudo aneurysmal sac, like that is actually pushing on the inferior branch and causing stenosis of it. So it is really like this is a dissection, no question. When I show you this imaging, there's no question you understand this is a dissection with a blind pouch sac from it that is pushing on the inferior division. And look at this also, like there's a little flap going also to the upper division. Another example, a patient with a stroke, right-sided weakness and aphasia, like, you know, this is a patient who goes to thrombectomy, but when you like you look at the CTA, it looks kind of a little ugly, a little like multifocal stenosis, not an old patient, you know, not really other evidence of ather, comes to the lab like for possible thrombectomy. You know, it's, what are you doing here? Like, what are we gonna do? Like, what are we dealing with? You know, it's really hard how to approach something like this, because it's not a focal, you know, stenosis that you can just take care of, or a thrombus. So this is a patient that we decide to follow, and actually, like we repeated, she didn't do that bad at all. We repeated the imaging 1 week later. We repeated the angiogram. Now with DynaCT 1 week later, look at this. There is an obvious pseudoaneurysm that developed from the superior division of the MCA. This was obviously a dissection. Now you see, starting to see filling of the pseudoaneurysmal component. And when you do the MRI, now you understand it also better here, because you see like the hematoma around the vessel. Okay, again, we didn't touch this. It was just an angiogram. So there's no question. This was not a iatrogenic. This was the disease the patient came in with. And then on the T1, you look on the sagittal view and you see like the intramural hematoma within the vessel. This is the follow-up 1 year later, okay, that show again, the vessel now is feeling much better, okay. And this is the follow-up DynaCT 1 year later that shows how now, like, there's actually like the true lumen M1, the original M1 is now like very stenosed. This was the bifurcation, okay. What is filling now is the false lumen that is filling the MCA. And what makes this case like so much more interesting is also the fact that the patient had a CTA done a couple of months before the stroke that shows like a normal MCA, completely normal MCA. And when you compare this normal MCA that she had before to the MCA now, you understand the bifurcation, okay? And you really understand that this is the true lumen M1, the original M1. And this was the double lumen that developed after the dissection. So intracranial dissection, we think that really cone beam is really important to assess and understand and interpret the disease. ICAD, what's the role for ICAD, of high resolution imaging? Mostly in understanding where the perforators come from, if you want to stent, like what kind of collaterals are present. And this is an example of a patient that, like after failed medical therapy, we decide to bring for stenting. And these are the 2D images that shows like this high-grade stenosis of the supraclavian ICA. And what is interesting here are the collateral pattern that are kind of a little odd. You see all these branches, and but with your 3D resolution imaging, like now you understand this vessel actually like is a superior hypophyseal artery that goes up, create a little network within the hypothalamic region, and then supplies the ACA territory. So it's essentially like a superior hypophyseal to a lenticulostriate territory collaterals. So something that has not actually been described, but you know, it makes sense if you know anatomy, vascular anatomy, this makes sense of a potential route. And this is before, this is, sorry, this is after stent, very good flow now. This is how it was before, this is how it is now. Post-stent imaging, this is another case. We're working on like trying to get the best possible images that show both the stent, the metal, and the vessel. And these are work in progress. Matthias, how many more minutes I have?
Let me check. So 7:15 now. You have like 15 more minutes.
Okay. So moving forward to spine. Spine is another territory where, you know, the use of this imaging is really important and necessary. And you know, for multiple roles, identify the anterior spinal artery, identify the fistula, understanding the microvascular anatomy when you do either tumor embolization or treatment of dural AV fistula. This is an example of a role that you know, we certainly had, like vascular surgeons in our hospital. They do the treatment with this Valiant Medtronic, like huge, like aortic stent, which you know, essentially covers all the way the aorta. So one of the probably the worst risk of this kind of treatment is that it can cause very frequently a spinal infarct. Why? Because you essentially cover all the collaterals to the spinal artery. So like, you know, there has been instances where the vascular surgeon wanted to know where is the anterior spinal artery come from. Okay, so maybe try to preserve, to not cover that specific segment in this particular patient. Now, think about the nightmare of doing an angiography in a patient like this. Okay, like think of going through every single segmental artery in a patient with this aorta. One role is really like to do a huge, big DynaCT. Okay, you inject a hole, it's a lot of contrast, but when you do that with one injection, you may have the answer that you want to. And indeed, like here, you see the anterior spinal artery coming from here. So now you can follow the branch and understand exactly where the branch that supplies the anterior spinal artery come from, and you can give a number to it, and you can provide very useful information. Patients with you know, this sort of like imaging obvious situation where you know you're gonna very likely identify a dural AV fistula, and once you identify it, to understand how to treat it, it's essentially routine to do this sort of imaging, because in this case you see the venous outflow in the spine, but you can follow the vessel and see really like where how is this segmental branch supplying the fistula, and here it is through this meningeal arcade, and then you can follow the vessel and understand that in order to treat the fistula, you can really have to go up and then down, and the fistula is going to be sort of like epidural parasagittal, and you know, go up and down like this, and this is where the fistula is. Now, once you understand the route, you know, going with a microcatheter here and getting to here, it's actually not difficult at all. The biggest work in such a case is to understand how and where to go, and how and which route to use. Once you identify that, this case becomes very easy. This is the glue cast after that, after identifying this, that identify exactly where the fistula was. Another patient with a dural fistula, in this case, where the imaging proved very useful, this sort of imaging became very useful. We find the fistula, left T8 injection, okay, a segmental branch injection. There's obviously a fistula, there is the vein going down, okay, but same branch, same level, there's also an anterior spinal artery, okay? So this becomes more challenging, right? Because you don't want to obviously to hurt the patient. Should this patient go to surgery? Certainly, that's a very good option, right? But let's try to understand a little better. First of all, there's another anterior artery supply, a little more dominant, like more like a Damkiewicz, like from left T12, okay? And when you do the DynaCT from the level of interest, okay, you see two things. You see two branches, actually. One branch that goes to the fistula and the other one that goes to the anterior spinal artery. They seem separated, okay? Now, something is very hard to understand in your 2D. Now, on the DynaCT, becomes essentially obvious, like in this drawing. You have two separate branches. It's not the same branches giving the anterior spinal artery and the fistula. They're two separate branches. So now, when you look at this, can you go separately into this in a safe way and cure it? The answer is yes, okay? The answer is yes, you can go selectively there now. and cure it, but it's something, and this is the final showing that preserved flow into the anterior spinal artery. The fistula is cured, the preserved flow in the T12. So you can cure the fistula and save the anterior spinal artery only if you understand how the specific patient anatomy is, and it's something you understand only if you do this sort of imaging. Changing gear for the last couple of minutes, you know, topics in which there's no really clinical role as of yet, but it really leads to a better understanding that can indeed eventually lead to clinical roles as well. MMA embolization, you know, MMA, you have all sort of variants. In this case, like, you know, you have a dominant, a single dominant frontoparietal branch. In this case, you have like more like a sort of like balanced supply. When you do MMA embolization for something like, you know, this hematoma, it's relatively common to see this sort of like blush filling of the membranes. Okay, can this sort of imaging lead to a better understanding of the physiopathology and the anatomy of this? We believe so, and we actually work on it. And we did a dynasty on quite a few patients, and we actually like start seeing, like really seeing the vessel going deep. This is an axial view. You see how deep this supply to these membranes, the chronic subdural hematoma membrane, it goes. And something led us to this sort of work where, you know, we also try to put it in this graph with the obviously help of a professional drawer, and that really like we put essentially together the information that we learned from the dynamic, information that we learned from the literature about this. And you know, you can see these vessels, this supply very well, and you can see the membrane. You can understand how really like it's this deep supply from the middle meningeal artery branch that supply this, and you can then put together in sort of like a little more artistic way. This is a cinematic rendering of this. And, you know, like this is obviously it's interesting. Does it have an obvious clinical role in understanding this? Maybe not yet, but like certainly like this is a role where this imaging provides interesting information. Now, there's also like another role for MMA embo, which is like understanding like the dangerous routes. You certainly see them on 2D DSA, but you see much better if you do any sort of other imaging. You know, the cavernous branch, obviously very dangerous. The pitcher's branch, obviously very dangerous. Things that we want to avoid. The recurrent cavernous branch, something that is a little less recognized, but essentially anything you see going medially here is going to be dangerous, right? And those are all things that we want to avoid. Another sort of like research role that we found is in the use of DynaCT to understand the vessels of the eye. And this is a cadaveric specimen from Dr. Moret that shows all the ciliary vessels in an orbit. Can we get to something like this today? Yeah, not quite, but very close. And look at this. This is how close we get. This is a 3D reconstruction from a DynaCT obtained from a common carotid artery. This is the posterior, the globe. Okay, you see all the ciliary vessels there, and you see the central retinal artery very well. Okay, and we know that from 2D imaging you see the choroid blush very well, but we know the choroid blush comes from mostly like from the ciliary vessels, not much from central retinal artery. Now, can you identify the central retinal artery here? It's kind of very hard. You know, by doing a DynaCT is not done for this purpose, it's done for other purposes, but the orbit is in the field of view, so you can work on it and play with it and understand. You identify this vessel, which has a lumen that is really like at the level of the resolution we can get with DynaCT. So we do see the central retinal artery. And now again, like on your 2D imaging is essentially impossible, but when you do your DynaCT, there it is. This is a central retinal artery, and then you go back to your 2D imaging and you can identify it. Okay, and this is an example of the volume obtained in a patient with a tumor here. Like this was a pre-tumor embolization. Now you follow the ophthalmic artery here. The ophthalmic artery goes back. Okay, and then there it is. You see on this coronal perspective, you see the central retinal artery perforating the nerve, going to the center of the nerve, And then from there it is, the central retinal artery getting to the posterior globe. And these are like just a screenshot of that central retinal artery in two views. And, you know, you can start playing around, doing 3D imaging, and understand the more distal part. Now, this is a bifurcation of the central retinal artery within the posterior globe. And again, this is just another eye. This is just to demonstrate like what kind of resolution we can get, what kind of understanding we can get of this vessel. And you know, this is, you know, essentially it's just like one after the other showing this concept. You start seeing things that you never heard of. A fenestration of the central retinal artery, never heard of. Like, you start seeing these things, okay? And this is the fenestration, seeing on a 3D images. You see like central retinal artery here, and then gives a recurrent branch along the nerve. Things that are almost like unheard of. Okay, you see a cilioretinal artery, which is like a well-recognized variant, but is something that is hard for us to see from in any other way. Like you see here, like so you see the central retinal artery, but you see also another vessel going to the retina. This is a cilioretinal branch. We put together this experience in a paper that was published recently in Radiology. We essentially, anytime we get this DynaCT, we can see the central retinal artery. What's the role of this? None yet, but, you know, can it be used to visualize the point of occlusion in central retinal artery occlusion, understanding the collaterals, differentiating acute ischemic versus non-arteritic ischemic optic neuropathy, pre-surgery identification of CRA? We can think about it, but certainly, like, you know, it may be a step forward in that direction. So to conclude, there's innumerable roles of this like increased imaging that our current machines provide us. And we cannot understand what we cannot see. So the more we see, the more we understand. We can apply this to any disease, like aneurysm, Dural, fistula, AVM, every single disease and condition you can think of. There's a lot to explore and understand. Limitations, certainly there are, you know, a few, like radiation. It's some radiation, and you have to keep that in mind, okay? Contrast, because in order to get this image, you have to give the right amount of contrast, and time consuming for, especially for the operator. It's not a long time to acquire this, but you know, it's a long time to post-process this image. The images I show are the results of a long post-processing. I wanted to thank again, my team, my mentor, Dr. Nelson, and Max and Ares. They're incredibly smart people that I'm so lucky to work with. And I invite everybody like to our neurovascular anatomy course that will be in at NYU this fall. To conclude, you know, that's it. You know, can this be useful? I hope so.
Thank you very much, Dr. Raz. It was incredible. I mean, so much visualization of structures that, I mean, at least I didn't imagine we could see. Any comments from Dr. McDougall before we start with the questions?
Yeah, that was really spectacular. I've been a fan of your work for a long time, and I had just thoughts running through my head as you were speaking. When I was a resident, I had a professor who said, you know, you're judged by your language. He was very meticulous about the language we used in speaking to patients and speaking amongst ourselves, being very precise. And your language is clearly the beautiful images and the anatomy, and it's just inspiring to see what you're able to do and the work you've put into getting the maximum amount of information you can out of those images. And then the other thing we used to say, you know, the cliche was that you treat patients, not images, but you know, you've just shown the power of the images and how much more we can understand and what, you know, how much better we can be if we really pay attention to those images. So it really is inspiring and also frightening when I think about what I have missed, what I have not seen, and you know, naturally patients come to mind from days gone past, the little perforator aneurysms off the basilars and those sorts of things that you know, we just couldn't see. So thank you for really opening up these borders to what we can see and understand and do. It really is wonderful. I would like to talk just a little bit about the accessibility of this kind of qualitative imaging and really integrating it into the practical work of the busy vascular lab, and how do we, I guess, democratize this ability to see that kind of detail.
Thank you so much, Dr. McDougall, for the great comment. I mean, it's yeah, like, you know, do we treat images? No, we really, like, I agree with you, like, you know, that's obviously we don't, but you know, the images like as I showed you, like, really, like, can sometimes give you a better understanding. Now I think it's very good to move to a more practical, like, you know, how to make this, you know, you said the word democratize, how to make this done. One thing that I want to say first is that you do not need you do not need a special machine to get this imaging done. You know, most of the images I showed, actually all of the images I show, are not from the last Siemens machine. It's not from an Icono. They're all from like an artist queue. So bottom line is that, you know, you do not need the last newer sort of machine available. What is necessary is really like the application of the right protocols, okay? That is what is absolutely necessary. Meaning that you have to select the right protocol, you have to inject the right amount of contrast, you have to reconstruct it in the right way, and the other very important thing is that essentially, if you want a high resolution sort of imaging, Dyna-CT, you either need a patient that is extremely still, or you need general anesthesia with breath hold. Okay, those are very important things. But with all these patient on general anesthesia, like, you know, again, I showed Siemens, but I know that Philips is capable of something very similar, and GE as well, with some time, because all the reconstruction take time. Okay, like it's an easy like you know, 20 minutes, half hour dedication for each case to really like reconstruct and work on the images to get them right. But otherwise, anybody with can get this. And that's actually that's the beauty of it. I think it's not a tool that necessitates any particularly high level technology. It's technology that essentially most of the labs have.
It's really us taking the time to learn it and apply it.
Yes. And you know, again, like you cannot be cheap on radiation and contrast to get this. Okay, unfortunately, like, you know, to get this, you know, it's gonna be more radiation. Yes, it's gonna be more contrast. Yes. Okay, it's if you really need it, it has to be on general anesthesia.
I think you can make an argument, though, certainly some of those cases you showed, that ultimately you save time and radiation just because your understanding was so much increased, and your pathway became, you know, so much clearer rather than trial and error, you know, catheterizing here and there and poking around.
That's a response to reviewer too. Just
so yeah, next a few questions.
Please.
So, is there any way we can find these protocols? I mean, did you publish about the protocols, or any site that we can find them? Maybe.
Well, the protocols, you know, again, like I'm concentrated on Siemens because that's a machine I know. The protocols are available on your machine. Okay, they're essentially, if you look at, okay, let's start, for example, with the Dyna-CT. On the machine, there are two default Dyna-CT protocol, 20 seconds. There's one 109 kilovolt and one 70 kilovolt. Essentially, the one that provides better imaging is the 109 kilovolt. And so that's a protocol to choose, okay? if you want to maximize as much as possible your resolution, you have to magnify to 22 centimeter field of view before the acquisition, okay? So that is gonna essentially activate a sort of like different way of that the images are acquired that increase the resolution. So that's again. Now, if you're getting a 20 second DSA and you wanna, let's say, an arterial view, you have to inject quite some contrast, right? Because you essentially have to have a full opacification of your vessels during a 20-second acquisition, right? So, you know, let's say you're in the ICA, you know, let's say it's a 3 cc per second flow, right? You have to multiply that by 20 more or less, right? Plus maybe some delay. So it becomes like a 60 cc of contrast injection, okay? More or less. Now, if you're like in a little segmental artery in the spinal artery, it's not going to be that much contrast because your flow is going to be much less and your injection is going to be like, for example, 1.5 cc per second, right? So it becomes like more like a 25, 30 cc.
Okay, in the post-processing?
The post-processing, once you have the images like loaded, if with the Dyna CT comes like only one sort of like volume, okay, which is the full like it's one volume that comes out of it. You load it and you play with it, okay. You start. Honestly, we learn by playing with it, right? You know, I'm happy, you know, even in another setting to go through a little more detail of how to get the images like, you know, perfected. You tend to use nip thin as a reconstruction mode. You can do like even smaller VOI reconstruction to increase the resolution, you know, and you start playing with it. And, you know, it's like video games, right? How to play video games.
Yeah.
You know, you play and you learn how to play video games.
Right. So next question, how many false negatives in DSA were positive with Dyna after subarachnoid hemorrhage in your experience? Do you have many cases of that? You showed a few.
I probably showed you like 3 or 4, right, or more or less. Maybe it's not that common, you know. It's not that common. You know, for perimesencephalic hemorrhages, we tend to do this. Not commonly, I found an abnormality. You know, it's still like rare to find it on Dyna than when you don't see it on DSA.
Okay. Do you have any experience with the application of this? I mean, your protocol is your post-processing in tumors, for example, skull-base meningiomas, let's say, to understand the vascular anatomy around the tumor or unpassaged vessels.
You mean intracranial tumor, you said?
Yeah.
Absolutely. And, you know, I didn't have time today to also show like the other topic. I had to choose topics. The other topic would have been tumor. Is essentially very similar to fistulas. You know, the images come out very similar to fistula. I show a tumor case at the end with showing the orbit. It just gives you a very, very understanding of the supply of it. Like, you know, we really like every case of a tumor, of a skull-based tumor. When you get this, it's actually like an anatomy lesson. You look at it, like just scrolling through it and recognize the vessel and give a name to it is an anatomy lecture. Now, that has also like clinical roles because you can decide where to go for, like, you know, understanding the dangerous anastomosis, right? And understand and visualize them better. Something, and then you can also see onto the DSA, but really like on those Dyna, it becomes so much easier to recognize.
Okay. So, okay, another topic. Sometimes we go for bypass, for direct bypass, and we cannot find a recipient vessel because we see that they are like sclerotic or they are super small and won't match. Do you think we could use this technology to select, to see if we have good recipients?
I think potentially yes. You know, I do work with you know, Dr. Nosek. He does so many bypasses. You know, we never discussed these possible roles. You know, it's an interesting question. We never applied it, but you know, conceptually, I would say yes. Because you can actually like if you get a common Dyna, you're right, you can see the superficial temporal artery branch, and on the depth of it you can see the middle cerebral artery branches. Really understand which one can be potentially a recipient close to your bypass donor. So I think it can have a role, yeah. Okay.
And you said that you can see the ciliary artery that is 0.2 millimeters, right?
The central retinal artery, yes.
The central retinal. So essentially, I mean, you can see any perforator, for example, before flow diversion for some posterior circulation.
Absolutely. Yeah. Now, can there be perforators smaller than that also that we don't see? Probably, but we do see perforators that are otherwise like very hard to see, you know. And you know, I showed you in such an example, for example, at the beginning when I show you that sort of like dissecting invert aneurysm, right? You know, those other perforators, you know, are hard to see otherwise, right? And understand exactly where they come from, right? That's a case that if you don't do that and you don't see it, very easily you may sacrifice just like 3 millimeters beyond and hit a perforator, right? So yes, we do see perforators, and we strategize the treatment based on that.
Okay, have you ever used this for if you have a high suspicion for a dural AV fistula in the spine, for example? Have you used this after a negative angio and found something?
Yes, we did, and specifically, essentially by applying the same sort of protocol that I showed you, that aorta to find anterior spinal artery in a vascular surgery case. You know, there is a fistula because, like when you do the orthogram, for example, you do see, but it's hard to really to understand where it comes from. You can do this. You do a whole aorta dyna, huge amount of contrast, but you do one run and you're gonna find exactly the route to go for it. Yes.
Oh, okay. Dr. Susanto here, one of our radiologists, is connected. Dr. Susanto, would you like to ask something?
No, thank you very much. That's excellent and illuminating and enlightening presentation. Certainly, some of the amazing anatomy, microanatomy displayed opens my eyes in terms of how to highlight these. Essentially, how can IV contrast CTA compete with such details, or even we've been trying. There's a difficult case for a spinal dural AV fistula, of course, that comes to mind when hearing me talk about dural AV fistula. So yeah, I'm going to continue learning in terms of how to display some of these microanatomy, vascular anatomy. Thank you.
Thank you so much.
I just want to comment something. There's from Dr. Russ, there is a paper about the identification with dynacity of supratentorial sinuses that are not usually seen, that were like less seen in the literature before. And I mean, its relationship with dural EVFs, and I mean, so this topic has like a huge potential for further discussion. Unfortunately, we don't have much time to continue with that, but maybe in another setting.
Yeah.
So those were my questions. There are more questions from the chat here. Alex Hen asks if dynacity has color encoding function for perfusion times.
Sorry, repeat. If there is a potential use for perfusion?
No, if there is color coding.
Color coding. Color coding is a little hard with the dyna because it's one. You can try to create a trapeze and sort of giving two colors, but it's not that easy to do.
Okay. Those were my questions. Thank you very much, Dr. Russ. It was amazing for us. Thank you for coming, taking your time for preparing this amazing lecture.
Thank you.
You're welcome.
Yeah, very beautiful. Thanks so much. Really appreciate it.
Thank you, Dr. McDougall. Thank you, everybody.
You have a great day.
Bye.
Bye.
Bye now.